I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. Today, I'm taking the second lecture on my series on posterior triangle. So the first one I've covered boundaries, contents and so on. Today I want to concentrate on the one single muscle, sternocleidomastoid. Why study this muscle, ma'am? One muscle, 20 minutes. Right. So let's see what are the commonly asked questions on this muscle. Write a note on sternocleidomastoid, write a note on torticollis, write a note on applied importance of sternocleidomastoid. Or remember, the sternocleidomastoid is an important anatomical landmark which gives you a huge insight into the neck itself. At the end of the lecture, you will understand why 20 minutes on sternocleidomastoid. Let's start then. How am I going to cover this class? Origin, insertion, relations, blood and nerve supply, actions and applied anatomy. The usual stuff, isn't it? How is it different today? Come, let's see. Right. So let's introduce the muscle. As you know, these are the boundaries of posterior triangle. This here is your sternocleidomastoid muscle forming its anterior boundary. The sternocleidomastoid is an oblique muscle which divides your neck into an anterior triangle and a posterior triangle. We know that. So let's demonstrate the muscle to ourselves. Okay, so bend your head to the right side, turn your head to the opposite side. This time, remember, you have to use your other hand to give pressure, preventing the turning. Okay, that will make your muscle even more prominent. So bend your head to the right side, give pressure, turn your face to the opposite side. Can you see the beautiful sternocleidomastoid becoming prominent? Yes. So this is how the sternocleidomastoid acts. By giving resistance, you can see it better. And this is, students, the first thing we've learned, how to test the sternocleidomastoid. That's our first learning. Let's move ahead now. Right. So we come to our origin, insertion, nerve supply, action, okay, which is how we learn about muscles, isn't it? So for origin, insertion, again I want you to palpate. What do you want to palpate? Palpate your sternum, manubrium sterni, palpate your clavicle. Palpate your mastoid process, which is a projection from behind your ear, and palpate your superior nuchal line, which is right there behind your head. These are the four bony prominences to which your sternocleidomastoid is attached. So sternum, clavicle, mastoid process and superior nuchal line on the occipital bone. The muscle itself has got two heads, sternal head and a clavicular head. The sternal head gives fibers that go to the mastoid called as sternomastoid fibers, to the superior nuchal line called sterno-occipital fibers. From the clavicular head, fibers go to the superior nuchal line, cleido-occipital fibers, and to the mastoid as cleidomastoid fibers. Funny, ma'am, you've given a different color to one set of fibers. Why have you done that? I've done it because these cleidomastoid fibers are deep. The rest are superficial, and in between these set of fibers travels your spinal accessory nerve. So let's take another look at it. Okay, so here's the sternomastoid, sternooccipitalis, cleidomastoid. These three form one bundle. Cleidomastoid lies deep to them, second bundle. In between them travels your spinal accessory nerve. So that's why we find that the spinal accessory nerve pierces the sternocleidomastoid. Okay, right. Can you see a little triangle here? This is called as the lesser supraclavicular fossa. Clinical importance. I only teach you if it's relevant. I don't teach random. There is a relevance to it. What happens is when you go down through this little triangular space, you hit the internal jugular vein. So an MCQ for this, a resident is attempting to place a central line in the internal jugular vein. She should place the needle at the following location to get the precise point of insertion. Where should she place the needle? At the jugular notch? No, you will not get internal jugular here. Between two heads of right sternocleidomastoid? Absolutely right. Yes, I won't go ahead and waste your and my time. My only question to you is why right? Why have they not just mentioned between two heads of sternocleidomastoid? Why have they mentioned the word right? Think, get back to me. I'll be happy to discuss this with any one of you. Okay? Come, let's go ahead. Some points to note before we go forward. Sternocleidomastoid is classified as a cruciate muscle. Anybody knows why? Why? Because the two set of fibers cross each other. That's why. Mastoid process is absent at birth. You only have development of mastoid process when the sternocleidomastoid begins to pull on it. So that's why it's sometimes called as a traction epiphysis. Okay? Let's now come to familiar territory, arterial supply, nerve supply. If you see, you can see the external carotid artery here, giving rise to superior thyroid artery and occipital artery. Both superior thyroid and occipital arteries give rise to branches that supply the sternocleidomastoid. What about nerve supply? Spinal accessory is piercing the muscle. Will it not supply it? Of course it does. Okay. Also, it receives proprioceptive supply from C2 and C3 fibers. Remember when you're asked nerve supply, and if you just talk about the motor supply, which is spinal accessory now, it's an incomplete answer. For a muscle as powerful as this one, it's important that you give the proprioceptive supply of C2 and C3 as well. So this entire screen must be your answer. Got it? So now we come to action. One unilateral action and bilateral action. If one side muscle is acting versus both side muscles act. Okay. So unilateral you already know. Bend your head to the one side, turns your face to the opposite side. This you already know. You know how to perform it. I'm not going to talk about it. Let's talk about a very important bilateral action when both my muscles are acting together. Here I want you to look carefully and perform the action with me. First, it extends the atlanto-occipital joint. Hold your head, okay? Let your thumbs go to the norma basalis. Turn your head up. Just the head. Don't touch the cervical vertebrae. Just the head. Extends the atlanto-occipital joint. Now flex your cervical vertebrae. This is flexion of cervical vertebrae. This is extension at atlanto-occipital joint. Now tell me, students, when do you actually carry out this action? Think about it. When do you actually carry out this action of extension at atlanto-occipital and flexion at cervical vertebrae? Is it not done when you're trying to look over a crowd? Something has happened on the road and you're trying to look over it. Do you not do that? Yes. So that is action number one. Give me a minute. Why am I having a spoon in my hand? Things are getting very interesting in this class, isn't it? Okay. Now imagine that you're eating something. Okay, you pick it up and then you take face forward and try to eat it. What are you doing? Extension at atlanto-occipital joint, flexion at cervical vertebrae. This action. Okay. So this is again action of sternocleidomastoid. When I do that, can you see my sternocleidomastoids becoming prominent? Because they're in action. Another thing is a very sad moment in our life. When we lift our head away from the pillow when we get up in the morning, both sternocleidomastoids act together. Students, I've given you some pointers. When you do these actions, try to ask yourself, really are my sternocleidomastoids acting? That way this becomes permanent memory. This is called as action memory. When we perform some actions, it is being noted in our brain. So study with actions. Okay. Bilateral action also helps in inspiration. So people, when they have an asthmatic attack, you'll find them pulling up their chest wall in an effort to breathe. That's also sternocleidomastoid acting as an accessory muscle of inspiration. That completes action. What have we completed? Let's revise. We did the origin, sternum clavicle. We did the insertion, mastoid and superior nuchal line, blood supply, nerve supply, actions. It's almost over. Not quite. We still have the relations to do and then we have to do the applied. Now we come to the relations of sternocleidomastoid. You must be wondering why is ma'am insisting on doing relations. Remember students, your sternocleidomastoid is a good 4 centimeter across your neck. There are so many structures beneath it. Okay? Unless you know about these, how are you going to find them when you're operating? So that's why knowing the relations is crucial. So my advice is know the relations of sternocleidomastoid to know your neck anatomy. Okay? So let's begin. This is a transverse section of the neck. You can see the sternocleidomastoid enclosed in the investing layer of deep cervical fascia, covered by skin and superficial fascia. The superficial fascia here contains platysma, external jugular vein, 4 cutaneous nerves. If you've been attending my earlier lectures, I'm sure you know them. One going to the occiput, lesser occipital, one going to your angle of mandible, great auricular, one going across the neck, transverse cervical, one going to your clavicle, supraclavicular. These are superficial to the sternocleidomastoid. Also superficial is a bit of your favorite gland, the parotid gland. Okay, so these are all lying on top of your sternocleidomastoid. Reflect them and then now reflect your sternocleidomastoid. What will you find lying below it? These are deep relations. Let's take a look. Now first an overview and then we'll discuss. Okay, so you can see that you can see the internal jugular vein, the common carotid arteries, some lymph nodes, a lot of squiggles of nerves, a lot of muscles covered by the sternocleidomastoid. So all these structures are lying beneath it. Let's discuss them one at a time. Okay. Before I get into this, I want all of you to relax. Maybe have a sip of water, maybe go get your coffee. Okay. Because now we're going into something which is concept building. I want you relaxed when you're doing this. Okay. Enjoy the process. Let me take my class and gently put in information into your brain. Okay. Okay, let's begin. So veins. Here as you can see the internal jugular vein, the subclavian vein lying beneath the sternocleidomastoid. So we are going to use this to quickly run through the venous drainage of the neck region beneath the sternocleidomastoid. So that's your internal jugular vein meeting with the subclavian vein to form the right and left brachiocephalic veins, which unite to form the superior vena cava. Have you got the picture? From here to your heart, the venous network. Internal jugular vein receives in the neck, below the sternocleidomastoid, the common facial vein, lingual vein, pharyngeal vein, superior and middle thyroid vein. What about the inferior thyroid? That drains into the left brachiocephalic. At the external jugular, which was superficial to sternocleidomastoid, drains into the subclavian. At the angle where the two meet, there is a right lymphatic and there is the thoracic duct draining in. All this is lying beneath my sternocleidomastoid. So when you're removing the sternocleidomastoid or maneuvering in it, you should know that these are the veins that are draining in and you might land up touching them. Okay. Next set of structures we are discussing is common carotid, internal carotid, external carotid, subclavian arteries. Such big vein arteries lying below your sternocleidomastoid. You know very well that the common carotid, the internal carotid do not give branches here, but the external carotid does. So beneath the sternocleidomastoid, you find the external carotid, which gives rise to ascending pharyngeal, superior thyroid, lingual, facial, and the occipital artery. What about the last three? The last three lie within the parotid gland. The posterior auricular, maxillary, and superficial temporal lying within the parotid gland. So all these are arteries lying below my sternocleidomastoid. Now we come to these so many squiggles. You must be wondering, how am I going to understand what ma'am is saying? You will understand. Come on. So here you are seeing C2, C3 and C4 roots. That means which plexus, students? Yes, it's the cervical plexus. Here you are seeing the brachial plexus. So both the cervical and brachial plexus lie beneath my sternocleidomastoid. Now let's see if you can recognize the rest of the nerves. Going to the occiput, lesser occipital. Going to the angle of mandible, great auricular. Going across midline, transverse cervical. Going to my clavicle, supraclavicular. Also seen here is the beautiful loop of ansa cervicalis, C2, C3 fibers, remember? And then there is the spinal accessory. What is not shown is the accompanying C3, C4 fibers and the vagus nerve. All these lie beneath your sternocleidomastoid. Can you go imagine looking for these nerves and unable to find them because you don't know the anatomy? Okay, let's talk about the muscles. Of course, there are a lot of muscles here. These are the supra and infrahyoid muscles seen. Let's begin to identify these muscles, okay? So here you have splenius capitis, levator scapulae, scalenus, posterior, medius, anterior. Which triangle did you see these in? Floor of posterior triangle. Yes. Now what about the other muscles I am seeing? Suprahyoid, posterior belly of digastric, infrahyoid, superior and inferior bellies of omohyoid, sternohyoid, sternothyroid, all under the cover of sternocleidomastoid. Right. We come to a very important part of this discussion, the lymph nodes. As you can see, there are a lot of lymph nodes lying on the internal jugular vein. These are referred to as deep cervical group of lymph nodes. These are divided into, I've put the muscles there because it's easier for you to understand. They're divided into upper lateral group of lymph nodes, which are called as jugulodigastric. See, the muscle running on top is the digastric. So they're called as jugulodigastric lymph nodes. Middle lateral group of lymph nodes, inferior lateral group of lymph nodes. Inferior are lying very close to the omohyoid, called as jugulo-omohyoid lymph nodes. In fact, they're just above the intermediate tendon of omohyoid muscle. Along with that, there is the sternoclavicular joint. Everybody lying under the sternocleidomastoid. Okay, so you saw a lot of structures covered by the sternocleidomastoid. Let me see how much you have understood. Ready for a little quiz? Let's come on. What are these? What is this vein? Is it common facial? Yes. This one, jugulodigastric lymph node. This one, jugulo-omohyoid lymph node. Vagus nerve, lesser occipital nerve, great auricular nerve, spinal accessory nerve. This one, brachial plexus. Ansa cervicalis. See, take your time to identify. Okay. Here's splenius capitis, levator scapulae, scalenus posterior, subclavian artery, subclavian vein, posterior belly of digastric. So now in this case, I want to see where the muscle is going. It's going to hyoid, so it has to be sternohyoid muscle. So this is how revisions help you to confirm to yourself, yes, I've understood. Okay, sometimes that is the role of revisions. We now come to clinical anatomy. So we've done the anatomy of sternocleidomastoid, we've done its deep relations, superficial relations. Now we just need to know what is its applied importance. One is the muscle is used as an autograft to repair surgical defects. It can be used as to create flaps of sternocleidomastoid to reconstruct orofacial region, tongue, larynx, etc. It is related to branchial cysts and branchial fistulas. Okay, I won't elaborate on it because I will be talking about it in my lecture in embryology. I want you to now come to an interesting fact, fracture of clavicle. Okay, so here you can see the medial fragment of the clavicular fracture, the lateral fragment. Remember, the medial fragment will get pulled up because the sternocleidomastoid is attached to it. The lateral fragment will be pulled down by the weight of the muscle, the limb itself. The limb is pulling it down. So the two fragments which were fractured, the medial fragment moves up, the lateral fragment moves down. A distance develops between the two. Meanwhile, the medial muscles of your chest pull the lower limb medially as well. Okay. So now the two fragments are dissociated, are separated from each other. What you do is you align them and then you give a sling to the patient. The moment the sling is there, the weight of the limb stops pulling the clavicle down, allowing for alignment and healing. Okay, that's again a surprising role of sternocleidomastoid in some fracture, clavicular. Right. We now come to another very interesting fact. Sternocleidomastoid has got a protective role. How is it protective? Now, if somebody is trying to cut off his own throat for committing suicide, when the moment they extend their neck, all the great vessels go deep. Now, if you attempt to cut, you cannot cut to reach the great vessels. Unless you cut the sternocleidomastoid and you cut the trachea, you are not going to be able to cut the great vessels, cutting of which actually results in death. Okay? So, that's the protective function of sternocleidomastoid. I won't elaborate on it, although I know this is the part that interests all of you, isn't it? Okay. Let's talk about a person who's come to me with a twisted neck, head bent to one side, face facing somewhere else, and this is the way he is. This is called as torticollis. Torticollis is of variable types: congenital, spasmodic, rheumatic, reflex, ocular. Let's talk about it. This comes as a note for all of you. Take a deep breath, relax. Okay? Let's talk about congenital torticollis. Here's a child whose delivery was difficult. The neck was pulled excessively when the child was being delivered. There is a little hemorrhage below the muscle. This hemorrhage later on heals by fibrosis, forming a thickening which is sometimes called as a sternomastoid tumor. As the healing takes place, the muscle slowly gets shortened. My mastoid process is now close to my clavicular head or sternoclavicular joint, and the patient now begins to heal like this. This, in fact, or even results in maldevelopment of the face and cervical vertebra. This is how his face develops. Head tilted to one side, face turning to another side. Okay, this is called congenital torticollis. You also have something called spasmodic torticollis, often of psychogenic origin. In this case, you might even want to cut off the spinal axis to relieve the spasm. Sudden exposure to cold might cause your head to tilt, rheumatic torticollis. Inflamed lymph nodes here might irritate the spinal axis, causing a reflex torticollis. Sometimes, see, you might have a visual problem. So you have one of your cranial nerves that's not working. So you turn your head in an effort to be able to focus at a point without using those muscles which are paralyzed because of cranial nerve injury. That is called as ocular torticollis. Torticollis that's happening because of a visual problem. So with this, we've completed sternocleidomastoid. Let's see if you can solve this MCQ. Following statement about the internal jugular vein is true. It drains the entire thyroid gland, does it? Just solve this MCQ, solve the next one. Torticollis is a condition resulting from spasm of the following muscles. It's easy. You better solve it. So with this, we've completed the sternocleidomastoid. We've done a couple of MCQs as well. Okay. While the muscle itself can be finished in 5 minutes, but the entire discussion on this with notes on torticollis and notes on its relations actually makes you learn something. Knowing mugging up origin, insertion, nerve supply action doesn't really teach you much. Okay? So do it in a way that you get perspective in the subject of medicine. Don't just do it because you have to mug up something. I hope you've got what I'm saying. So finally, as your teacher, I want to advise you, your future is decided by what you do today, not tomorrow. So don't say, I will study this tomorrow. Study it today. It's fine. Okay? So as usual, I enjoy taking this class, students. Okay? I hope you did too. See you across the screen in some other lecture. Thank you.